Awesome. Good afternoon, everybody. Everybody's eating lunch, and I haven't had lunch yet. It is a pleasure to be with you today. My name is Adam Campbell. I'm the Vice President for Patient Safety and Quality for Erlanger. And it's really good that we're talking quality improvement methods or improvement science methodology today. With this class, we would love your input and your sort of buy-in on how do we build quality improvement and project support for the residents. So the biggest part of that early on is education on the methods themselves. So we'll be getting into a little bit of didactic today. And in the near future, there's going to be opportunities for workshops where we can do some table work on projects that you're identifying for your subsequent years, and we can work through those and see how we use these tools in the context of the projects. So how does that sound? It's all about working with Dr. Bennett and Dr. McCart to kind of put this together, and would really love any feedback you have on how to work through this process. But today, over the next hour, I'd kind of like to talk about methods, and not only methods of how we improve, but what's the construct of all this? What's the philosophy behind all this? What does it mean for the organization? So within the next hour, we'll kind of do a high-level view of this, and you can kind of see where projects you may be interested in will fit into this. So the first part of this is, and this comes from Frankel in 2017, that there's a basic framework for how we look at quality, safety, and service within the organization. It boils down to two things. This is hardcore philosophy of all this. The first is you have to have a safety culture, quality improvement minded culture. And a lot of this culture is based on transparency and is also based on non-punitive environments. We have to raise issues. We have to raise problems, things we need to fix. So that's what we do. All right, together we look at our processes and say what needs to be fixed. And once we identify the issue, we have to have good standardized methods for how to improve. So it all goes together, but the first part of this is a non-punitive, sort of like safe environment in which we can identify issues. And of course, the other part of that is accountability. Right? How do we hold people accountable to get things done to improve? I will tell you culturally, that's probably the hardest thing to do, right? But that's where leadership comes in. Okay, that's where we really have accountability structures that, as you'll see as an organization through certain frameworks, so we can make that happen. And the second part of this, which is really germane to what we're talking about today, is philosophically we have to be a learning system. Of course, that goes from philosophy to pragmatism to function really quick when you're looking at how we learn as an organization. And it seems really broad, right? You want to learn as an organization, but how you do that? Well, that starts with each individual project. And it's sort of a gestalt mechanism where you're looking at all these individual projects as we're improving over time, add up to better processes and better outcomes. So that's the learning system. We'll talk a little bit up front about this concept of reliability, where we have to do standardized or evidence-based practices. We have to train to them. We have to do them reliably each and every time we have the opportunity to do them. And if you have dropouts from that, that's where improvement takes charge. So what does high reliability mean? In healthcare, in this domain, we borrow a lot from other organizations, other types of organizations, things like nuclear power, commercial aviation, naval aviation. These are organizations that are very complex. And what happens in this complexity is you have a lot of variability in this complexity. Healthcare is exactly like this. I would posit that healthcare is probably the most complex system that you could possibly work in, even more than landing a jet on an aircraft carrier. The last 7 years I lived in Norfolk, Virginia, so there's a lot of Navy folks floating around there that kind of argue that. But I would say healthcare, highest level of variability, highest level of complexity of the system. So how do we manage that? We manage that through improvement science. And when you look at the different things that really relate to aircraft carriers and jets landing on them, look at all that variability from the pilot to the equipment, to the weather conditions, to everything, makes it very hard to land. Healthcare is the same way. Think of how we interact with patients, all the medical equipment we need, all the processes that need to be in place, all the education and training that needs to occur. That's where the complexity is. So we have to manage, as a highly reliable organization, we have to manage this variability. Part of improvement science is standardization, right? And training to that standard. And high reliability organizations do a good job of managing risk. So how do we manage risk in healthcare? Well, we have to look at our highest risk components of what we do, and we have to make sure that they're running appropriately. It takes a lot of data to do that, usually, right? Every process that we have should have some data mechanism around it to make sure it's operating smoothly and effectively, especially in those high-risk areas. And I'll get into how we do that in a moment at a high level. But high reliability organizations, they operate in these highly trying conditions with fewer than their fair share of accidents or events, right? That's what we strive for in healthcare as well. That's what we strive for at Erlanger. So here's how this looks, okay? There's things we can do to increase reliability. The first, and it's actually the lowest level of reliability, is evidence-based practice. Bundles of care, bundle reliability. How do we care for a central line? How do we care for a catheter? Okay, there's very specific ways in which we do this, right? So that's the lowest, that's process design. You're designing your processes to get the best outcome around the best processes. The next step, and over here on the left, you're increasing reliability. And what that means as you increase reliability, you have fewer and fewer events or non-conformities per million opportunities, right? So as your opportunities go up, you want your, what they would call aviation accidents, okay, you want those to go down. The next level in which you do this is reliability culture. Like we just talked about in Frankel's model, you have to look at these things. You have to hire for fit. You have to have core values, right? You have to have integration of your committees, your communication, your teamwork. All these things go into what creates a reliable culture. And probably the biggest thing of all, we talked a little bit about a safe environment to raise issues, is you have to have a just culture. Right? We know there's very rare instances where people do things just out of neglect. Very rare. But there's also times when you will be or possibly involved in a safety event, something we need to fix, or in a process that's not running smoothly to fix. That's where the fair and just culture comes in. You can't be held accountable for that, because our theory to that is, and this comes from Deming back in the 50s, right, is individuals operate within the system that's been put in place. That system is all of our processes, all of our culture, everything wrapped up. But it's the system that really guides the actions of the individual. And that's really what we're going to fix system issues when they arise. And the highest level of reliability is really when you start getting into human factors, making it extremely hard to do the wrong thing when delivering care, delivering support, and make it very easy to do the right thing. A lot of biomed goes in this direction, a lot of organizational design, hospital design goes in this direction when you're building new facilities. So a lot of human factors really bakes in doing the right thing. So that's how you really get to the highest level of reliability. And in all three of these areas, we can have improvement opportunities. So how do we measure quality and safety in healthcare? A lot of it's a reduction strategy, right? We want to reduce infections, we want to reduce falls, we want to reduce readmissions. So a lot of the things we do in quality and safety and services reduction. But on the flip side of that, there's a lot of things we want to increase. We want to increase reliability, we want to increase compliance with how we do certain things, we want to increase quality of care, increase safety. Okay. So this reduction strategy brings us to zero harm, while the compliance brings us to 100% reliability. So those two things interact, of course, with process and outcomes. You may hear, Lean Six Sigma, right? Lean Six Sigma encapsulates that strategy. Reduction strategy is a reduction of nonconformities, reduction of errors. That's Six Sigma in a nutshell. What can we do through improvement science to reduce nonconformity? That's what manufacturers are calling it. We call it a safety event, we call it a reignition, we call it a fall. Okay? The lean part of it's the efficiency part. How well our patients move through the system? How well do we communicate? How well are our supplies managed, et cetera, et cetera. So you have a Lean Six Sigma strategy where you're looking at efficiency and effectiveness. And that's really where that goes as far as the philosophy of quality improvement. So you have three different process ideas here. Let me go over really quick. The first is process capability. All right, when you start looking for things that need to change, and they're out there, can't avoid them. Okay? That's our job, right? You have to look at process capability. How well is the system built, both through resources and structure, to support improvement? Okay. We have to look within our improvement sciences. Do we need more resource? Do we have the capability to do certain things? And that leads to process reliability. If we have the capability to do these things, then we can start talking about how to improve the process. An example of this would be if we want to increase how efficiently we manage beds, but we have nowhere to store beds. Sound familiar? It's every organization, unless you take this in human factors wise to another facility. All right. That's what I'm talking about. We have the capability, the capacity to store beds. And that leads to processes we can improve bed management. So that goes together with capability and process reliability. And of course, the icing on the cake is process improvement. How do we use these methods to improve to the highest level possible? And oh yeah, we have to measure everything. So we'll talk a moment when we start getting into some of the improvement methods about how you select measures and how you sort of manage actual metric creation and collection. But again, I'll leave this part with Deming, where he says, if I could tell management one thing, it's that it all boils down to the reduction of variation. Okay. Think about everything you do on a daily basis. How much variability is in the process? You want to get rid of it. We can actually statistically monitor this. Okay, and we do this through statistical process control charts. And as we work through your first year and into your second year and third year, you're going to be starting to create these things. You're going to be a statistical wizard. Okay, most of you could probably know, and some of you may have done things like this. What is statistical process control? It's a trend chart, looking at data over time. So if you're going from left to right on this, this could be monthly data, weekly data. But we want to trend data. We don't want individual data points to drive our improvements. It's not really a good standard. So you have to look at things over time, and you can look at two things on a statistical process control chart. The first is the big, bold black line, and that's our level of performance. Right? If this is compliance, we want that to go up. So we can put changes in place using these methods to increase what we need to increase. We see the bold line moving upwards, so we're getting good performance. Each one of those dotted lines, the black dotted lines, the vertical lines, could be where a change occurred. Because you're monitoring the effects of change across your trend chart. And those red dotted lines, those are your variance limits, called sigma levels. So you go out plus minus 3 sigma from your central tendency, that bold line, and you can see the effects or the level of variation. So what you want to do from left to right is not only move your black line, but you want to squeeze your control limits, your variation limits. Okay? That means you're improving performance and getting variability out of the system. Cool? Cool. And if you get a chart that looks like this, you're running pretty good improvement. So that's our goal in everything we do. Why is this important? Because statistically, we have to know if our effects are real. All right. As we change, how can we explain improvement? If you have something at the top, and we see this all the time in the literature, before and after effects. Hey, at less than 0.05 alpha level, before change and after change are different. Okay. But if you look at the 3 graphs on the bottom, there's different ways you can get to those before and after data. The one on the left, the bottom left, is what we would hope would happen. We have a certain level before the change and a different level after, and it drops off a cliff. That change made the difference, okay? That's what we would hope would go into the blue bars at the top. Oftentimes, this doesn't really happen. Okay? It could be the scenario in the middle where it's a gradual change over time that may not be related to the change that you made. Or it could be at the left where you go down very rapidly, but at the very end, your performance starts to tick back up in a negative manner. So you have to look at the trends and the effects of your change, and that's a big part of improvement science. Another thing we do not see in any of these are what? What's missing from the column graph at the top? What's that?
Significant.
Well, significance, yeah, we'll assume that it's significant, but there's no error bars on this thing. So I did that on purpose to say, if you're not looking at error and you're not looking at variability, you don't see variability limits on the bottom either. So that's very important. It's why we use statistical process control. There we go. So statistical process control is really based on the normal curve. Every single data point is going to be within some type of distribution, right? We always use the normal curve for everything, but less and less in nature are things ever in the normal curve. All right, a lot of things are non-parametric, which outside the scope of our hour today. But if we look at a normal distribution, in the tails of these distributions is going to be a very small number of observations of data points, right? That's very important when we're looking at how we look at performance and how we look at trends. I liken this to a kicker in football. The kicker, among other things, has to kick field goals. The best thing a kicker can do is every single time kick the ball right down the middle, through the uprights right down the middle, right? Even, you don't want to even hook it and come close. So if you do this, the good kicker will keep everything right down the middle on your mean performance. And if he gets really good, you can actually squeeze the goalposts together and he can still make it, okay? But if you start having nonconformities, you start having things that go outside of those variation limits. Think of the goalposts as variation limits. These are very low percentage things that happen outside of the normal flow or outside the variance limits. So what happens in a control chart is if you, I hope this never happens in a stadium, unless it's a celebration. You can turn goalposts on their side. And lo and behold, those variation limits can become a control chart. So every time you have one of these normal curves, you can put it at any given point in time. And you're monitoring performance. For that collection of data for that month, as you go across your chart, you're going to get a mean or a median for that group of data. And you're going to get variance limits for that data. And you just monitor that over time. So the goal is at each step, you want all these points to be pretty consistent. Okay. And when I say all those points need to be pretty consistent, what is that? Low variation, right? All those dots are pretty similar. That's what we want. Is that hard in healthcare if you're dealing with patients that have a lot of variability walking in the door? See a lot of nods. That's what we do, right? So here's what a SPC chart could look like. And there's different rules. And these are rules that are really based on Institute for Healthcare Improvement rules. The most important of these is this one over here. If you get 8 points below a center line, you can shift that performance in that direction. That is, that 8 points is statistically significant within the trend chart. So if you want to say, okay, this is our monthly performance on number of CAUTIs, and Lord, I hope not, because the frequency is like 80. But what you want to do is reduce that. So if you have strategies like in June or July, when this really came up here and you performed a change, and over the next 8 months or weeks, you saw this happen, you can shift that down and say, hey, we got a significant trend here. Okay. So again, that's the beauty of SPC. All of this is overseen by an organizational strategy. We are accredited within Erlanger by DNV. Who's interacted with D&B when they come in the door? Yeah, I got a couple. So they come right around and they look at how well we meet the CMS conditions of participation. Okay. Big binder about that big, it has all these rules in it that we have to meet, they check us for it. And keeps their doors open. So we're really good at that. Well, the other thing D&B does is you can become certified ISO 9001. Who has heard of ISO 9001? All right, that's fine. So ISO 9001 is a set of criteria for how you build a quality management system. A quality management system encapsulates everything we just talked about. How do we identify problems? How do we resource the problems? How do we know what we need to improve? Do we have standard methods to improve? Do we have the committee structure, the communication, the teamwork, the culture to support this? That all is ISO 9001 standard criteria. And we have to meet that. Happy to announce, as of February 16th, we have gained our certification for ISO 9001. Only full hospital system in the region to do it. Thank you. So that's the work we're continually improving on. And it helps us set up the quality management system to do this work efficiently and effectively. So the first thing we need to do is define our key processes. A lot of this goes, of course, onto care processes. We have to look at the variation we have in how we care for patients and how we can reduce that, and how we get a consistent product with high reliability. Once we define those key processes, in this case, care processes, how do we manage them? How do we measure them? Right? How do we know we're doing well caring for asthmatics? All right, or in the GI clinic? How do we know we have to measure our processes now? And we're monitoring all these processes, and it's a lot to do. We have to identify when they're not working appropriately, where we can improve. And that's where, down here in the bottom left, is the quality tools, using things like we'll talk about in a moment, demand, project management. Okay. How we use PDSA cycles. How we use a bevy of tools, including statistical process control, to improve. This can get into redesigning processes. This can be small change that makes a big difference, a lot of different things. So this is the quality management system engine, and this kind of just summarizes everything I just said. It's a simple input-output system, really. So you have all your system inputs, customer expectations, the expectations of the patient, the expectations of D&B and CMS, the expectations of the community, financial expectations from the C-suite. I mean, this is leader-driven. Right? There's expectations and objectives by the board that allows us to roll this. We put it through the engine, which is this is your ISO 9001 clauses in a nutshell. To our leadership, sets your strategic plan, resources it, monitors it, and if things fall out, gotta approve it. ISO 9001 criteria is like 30 pages. Pretty easy to read. Costs about $250, so that's another matter, but it's very easy to read and very short. So I recommend looking at those ISO 9001 criteria. It gives you a good indication of how we run this as a business. And of course, with improvement and with monitoring and with resourcing, we have good system outputs. Zero harm, right? Good quality, good financial outcomes, or good for the community, et cetera, et cetera. So this is ideal state, and we're working toward this ideal state every day. What does this mean for training? What does this mean for education? Like hopefully we're doing a little bit today. Okay. I liken it to Formula One. You've got 21 people in a pit crew that are highly trained to do a very specific task, okay, or a set of tasks. When they have good communication, when they practice a lot, when they do this, so it's almost a habit, unconscious, in the way they do it, you start getting to very high levels of performance. This is what we strive for in healthcare. You see, like less than a 3-second pit stop on this sucker. That's what we want to train to. That's the beauty of training and how we identify those processes and techniques and improvement methods, how we train to them to such a high level that we're getting this like Olympic performance or Formula One performance. And oh yeah, we have to do this under high levels of stress. No big deal. If Usain Bolt can do it under high levels of stress, we can too, right? So keep that in mind. Olympic athletes, F1 pit crews, high levels of stress that they bake out because they're highly trained and they know how to improve when things don't go right. So that is the 25-minute philosophy of healthcare and statistical process control. We'll get more of that and more into that in the coming weeks and months. But I'd like to finish up today by really looking at improvement science methods. And these are simple tools that you can use when used as a bundle, right, to have certain aims, can affect improvement. Right? This doesn't have to be a big project. It can be very simple things you can do for large effects. And why this is important is because in any situation in healthcare, for quality and safety and service, this needs to be decentralized. This is training an organization to handle improvement at the local level. And any good organization strives for that and puts processes in place to make that happen. So for the rest of today, we're going to focus on the big red dot, okay? Improvement science. These are senior leaders are evaluating and doing management reviews and looking at tons of data. And we start looking at things that may not be going well. So we start looking at change processes. What you will quickly see over the next 20 minutes or so is that a lot of improvement science, although, given that there's very specific methods, boils down to two things: good project management, so it's accountability of the project, how do you make sure it's on track, et cetera, how do you measure the right things, all that good stuff, and change management. So the more acumen you gain with improvement science tools, you're gaining project management and change management skills. Okay. And a lot of this has to do with how do you get people on board? Right? How do you change people's minds on the need to improve? Okay. It gets a lot of change management. Pick up a copy of Crucial Conversations and give that a read. And there's a lot of good techniques in there to look at change management. And on top of project management and change management, you get into your Lean Six Sigma capability. And we'll talk about some tools that make that happen. So the first thing is really on the project management side. I want to talk a little bit about the MAG. This is really a technique that was born out of Toyota Production System and other types of methodologies. They all kind of came together. Motorola, GE, all these big companies that started getting into the 70s and 80s are like, we want to embrace the quality improvement strategy. And this was really born out of that. So what is DMAIC? DMAIC is, like I said, a project management strategy that, one, allows you to define the problem. Second, it allows you to measure the current performance or baseline performance of what's going on. So you're substantiating the problem, one with data, and one with an understanding of the process itself in its current state. Okay. Third, you analyze the process. Okay. And we'll show some techniques here using things like fishbone diagrams, SIPOC, process maps, things we have at our disposal to kind of understand point by point how the process is working. We have to analyze why there might be gaps in that process. Okay. And then we get into solving the problem. And that gets into a DMAIC, the I is improve. Pretty shocking. So you have to have improvement strategies like PDSA or other change strategies to really make sure the change is happening appropriately. And at the end of DMAIC is control phase. Can we sustain improvements? So every project we have, think of DMAIC. I would suggest that understanding the problem, the D, the M, and the A, is probably about 70 or 80% of the project. That's a lot of work. And then once you analyze all those gaps in the process, will lead you to specific interventions, changes, right, that are linked to the gaps in the process. All right, so once you start looking at DMAIC, I would suggest asking 3 questions. Now, this is what's known as the Institute for Healthcare Improvement Model for Improvement. Okay, you can go on YouTube. There's a lot of cool videos from IHI that gets into a lot of this. They're cool whiteboard sessions and all this. You have to ask three main questions. What are we trying to accomplish? What's the goal? Now this goes early into defining things. This is like, whoa, we might have a problem. What do we need to do about it? We need to improve it. Right, start asking these questions. The second question is, how will we know that a change is an improvement? What's the easiest way to do that? Measure it. All right. You have to come up with specific metrics that allow you to define and measure the problem and measure performance. And third, what change can we make that will result in improvement? That's just coming up with interventions, coming up with possible changes, coming up with a schedule to start testing it. We'll see in a moment when we get deeper into PDSA cycles, plan, do, study, act cycles, that these are very deliberate changes, right? You don't throw the kitchen sink at something. It has to be very deliberate, has to be very pragmatic and studious. So here's a problem statement. All right. I apologize in advance to Dr. Bennett on the pediatric side, but this comes in a pediatric scenario. But this is hypothetical. This is not an actual issue.
This actually never happens.
No. Peds is perfect, everything else is not. So it's just an example I came up with. And here's a 7-day readmission rates. Actually, our readmission rates are pretty good across the board. But hypothetically, we look at the data, we see trended data, we monitor our readmission rates across the board, actually we do. And we say, uh-oh, our 7-day readmission rates are above baseline. And it's above where we want them to be. First of all, how do we make that determination? How do we know they're high?
Measure them.
Yeah, you measure them and you try to measure them to a comparative database, right? Industry standard. What should readmission rates be for a children's hospital that looks like ours? Okay. So we, because we're a great organization, have access to that data. Okay. And we know the effects, the problem statement. So what are the effects of readmission? Well, it bogs down the ED. It's terrible for the patient and family. All right. Nobody wants to come back to the hospital. Nobody wants to come back to the ED and possibly get admitted. Right. So it's a stressor. It's a stressor clinically. It's a stressor financially for the organization. And actually, on the adult side, we actually get penalized for certain readmissions. So it's a bad deal. Okay. We don't want them. And first and foremost, it's not good for the patient. So what do we want to do? We have to understand the problem. So within the define and measure phase, you have to go to our data. This would be a hypothetical statistical process control chart that shows our performance to the comparator being in green. Other pediatric hospital performance. Our readmission rates overall are about 4.6%, and we need to be down about 3%. That's a big gap. Actually, about a 50% gap. Okay. So we need to improve. So this is where you start looking at your stakeholder analysis, who needs to be involved in the project, and understand your data more. Right, these are key decisions early on in define and measure that you need to get a handle on. The other thing you need to do is, what other type of data do we need? If those are overall readmission rates, do we know where to improve? Who to reach out to? What's one thing we might want to know about the readmissions? What service line are they happening in? All right. Are these asthma patients? Are these GI patients? Are these whatever? We have to know where those patients are being readmitted, what service. Okay. And that gives us a better clue of who we need to reach out to start making big time gains, more bang for the buck kind of way. This is all hypothetical, by the way. Post-discharge issues. You start digging in and you start talking to case management, you start talking to primary care about readmissions. Maybe we start finding out, well, we got a lot of drop-offs of people getting their medical equipment. All right. In our asthma clinic, where people are being discharged from the service, nobody's getting oxygen, or nobody's getting inhalers, all their meds are messed up. But those are issues we want to define. Right? You see how we're starting to clue in on what our interventions could be or who we need to talk to in the define and measure phase. Then you can start breaking down patient demographics, age, are there any equity issues that may be involved, all different types of things. that really allow us to clue in on how we can strategize about this issue. So it's never just your outcome metric. If you start getting through the measure phase and the only thing you see is your overall readmission rate, don't have any other data, you're not going to have enough to really be pinpointing your interventions. And the best way to start the project is to have an idea about what goes into the project charter. This is who's on the team, what's the goal, how often do we meet, who's this report to, right? What's the committee structure look like? You know, what's the change management look like? It all goes into the charter. And I will say, we'll talk about this more in the coming months, but stakeholder analysis is extremely important. You gotta have the right people at the table. So there's actual templates we can use for project management, right? Put these things together. And it really is a scope management document. And it's a good elevator speech document. Not that we have these in our back pocket or walk around the hospital, but if Dr. Jackson is standing next to you in an elevator, Dr. Woods is standing next to you in an elevator, oh, how's that readmissions project going? The first thing you should do is have the project charter memorized. Here's the structure, and here's our current changes we're testing. Right? You have that, your 30 seconds will be up, and everybody have a smile on their face. So there's very specific ways in which you come up with a goal for the project. And this is done with all stakeholders present, with the data in front of you, knowing what type of increase or decrease you need for your goal. And this is off the IHI website. IHI has sort of a quality improvement toolkit where a lot of this resides. So they have an aim statement worksheet, and you kind of work through this. I'll just tap through this. I like to color code it. Okay. So what are we doing? Readmission reduction. How much we got to reduce? Right. We know we need about 50% reduction in this case. So we need a 15% reduction overall. Let's start something that's manageable. That's part of a SMART aim. Is it manageable? Right? Is it achievable? By when? So by December of 2022, we're going to sustain this for a certain period of time. Always have a sustainability factor. And this is for patients discharged in the past 7 days from inpatient and observation status. So that puts together a very nice goal statement. It has all these elements, time parameters, percent reductions, for whom. Okay. This can actually get more specific. If you know that there's a large issue, let's say on the endocrine service, you can actually put in for where or who this applies to. You can be specific to a service or a division or whatever. But this is a very important thing to work through, and you work through this as a team to come up with the goal. Can the goal change? Well, yeah, if you meet that 15%, what do? What's the next step? Let's realign the goal. Let's go back to our data. Okay. So once that goal's in place, you really have to start rolling up your sleeves on understanding the process. And again, like I said, a large percentage of your work is going to be in process mapping. And this is through basic observation. You cannot process map from an office. Right? No matter what the process is, one, you have to talk to the people involved in the process. So there's an interview component to it. But to the best of your ability, you have to go see this in action. And Toyota production system is called Gemba. Go with the work habits. Right? That makes sense, right? Quality improvement. So when we're looking at, we discuss with the stakeholders and we identify that, well, one of the biggest things we need to improve to stop readmissions from continuing is make changes to the discharge and post-discharge process. Okay. So you want to observe that. Okay. You actually want to go grab a clipboard and a template, a stopwatch, and look at what happens when you're discharging a patient. First of all, can you do that in 15 minutes? No, discharge is a pretty long process, right? So that's why I'm saying there's a time commitment. It's a pretty heavy lift at this point in the project. But you have to try to identify each step of the process very specifically. This is very high level what's on the screen, but this gets us into pre-discharge. Okay, what happens at discharge or leading up to discharge? Things like medication reconciliation and education, follow-up visits scheduled, et cetera, et cetera. In discharge, if they're able to get home, they have transportation, they leave the hospital. Once they leave the hospital, there's things we do, right? They have to make it to their appointment. They need to get their meds. They need to have a follow-up phone call, perhaps. A lot of things need to happen post-discharge. If any of that fails, it could lead to a readmission. Okay. No good. So once you get the process map, you start identifying, I call them blasts. Where's the gaps in the process? And overlaying these blasts where the process is failing. And very important, what does the fallout look like? Something needs to occur at that point, but it's not occurring. It's not happening appropriately. It could be a lapse in medication reconciliation. It could be a lapse in follow-up phone call. Okay, we have to find out what that is. Okay, and what if follow-up phone call, compliance is not being measured, but it could be an issue, or we find out that it's not happening at all. Right, then you're getting into creating service to the customer. So a lot of this is identifying where the gaps are. You can also use what's known as a swim lane diagram. This is an example. It's not related to readmissions. I think it's actually the admissions process. I got to sit down and make one for a discharge one day. But this identifies the process left to right, and then from top to bottom, it's everybody that's involved in the process. So you're starting to get a smaller level of granularity on who controls that part of the process and when does it happen in the total process timeline. Another level you can do is each one of those arrows that's in the swim lane is a communication type. Okay, so how is A communicating with B to accomplish C? And that works all the way across your process. So you're looking at who does it, how are they communicating, and is each step happening appropriately? Is this sounding easy yet? It's really not. That's why we're here. Okay. Let me tell you, tiny guys, wizards. Great. So if you haven't delved into Visio yet, who's used Visio? Right. Oh man. Get you some Visio. Well, Microsoft product. And you can make like work charts and stuff in there, but you can also make swim lanes and process maps. Pretty fun. Try to find a free copy. It's saggy, big letters. But if not, get you a big sheet of white paper and some sticky notes and go to it. Okay. And the process map. The best thing you can do, and senior leaders love to see this like this. A whole wall is your process map with sticky notes and people around it, and they're putting sticky notes up. It's classic, and it's a good way to do it. It allows for conversation around the process as you're building it left to right. Really cool. So just something to throw out there, swim lane diagrams as you're analyzing the process. Another thing you can do, you can use is called SIPOC. This is extremely important for two reasons. All SIPOC is you put your process right down the middle. That's the P. And you want to start looking at every step in the process. What's the input and output for that part of the process? Who controls it? And who's the beneficiary of it? Okay, so S is the supplier. Who supplies the input to that part of the process? Okay. Second is the inputs. That's all the inputs that go in the process, the inner process. Well, that process is going to create outcomes at each step. And we have to know who benefits from that output within the process. It's usually the customer, which the customer oftentimes in a SIPOC or a process map is the next person in line with the care of the patient. So we're customers to each other, not just the patient, or the payer, or whatever. We're customers to each other. It's very important. So SIPOCs are pretty easy to put together once you have your process map. This also allows you to look at one, we need to have measurements around the outputs, right? And we need to know who the stakeholders are, who the suppliers are. Those are your stakeholders to bring onto the team eventually. All right, so we're through D and M, almost getting to A. Final 15 minutes, we'll finish it off. All right, so one thing you have to look at as well is what are your measurements going to be? And we'll spend a lot of time in the coming weeks and months of how do we identify the right measures. Well, there's templates on how you define the measures. It's makes it a little bit easier. Okay. But it's really a process to go through to make sure you have those process metrics that are supporting your overall outcome metric. Okay. An example of this is in the readmission example, A process measure would be, what is the compliance of follow-up phone calls, making contact with the patient? Okay, that's a process measure. Our outcome metric is, were they readmitted? What's the rate of readmission, or frequency of readmission? So you have to have all these process metrics around the process that you're trying to improve. Another way to break this down, and it helps you identify measures and issues, is the fishbone diagram. Are there mechanical things that need to change? Are there capacity things that need to improve? On and on and on. So each little bone of the fishbone is going to be a category that has these sub-issues in it. Okay, so when you're looking at your process map, you can kind of, this is a way of organizing all the issues that you see coming out of a process map. You can put them into a fishbone diagram. And if we glean anything from today, we want to really look at learning a tool, I recommend the key driver diagram. Look what the key driver diagram does. And anytime you share this work, or you have to give an update on the work, always have your key driver diagram with you. And this is why it's so important. On the left is going to be your goal, your SMART aim. What's the overall aim of the project? As we move from left to right, going into the goal is a series of buckets. All right, the main drivers or issues that are causing us not to meet our goal. Okay, so in readmissions, it could be communication issues, education issues, services, analysis and transparency. So when you start seeing all these gaps in the process, you'll be able to start grouping them. Those groupings are grouped into what are known as the key drivers, hence the name of the diagram. And on the far right, this is just a list of your interventions that go into each one of these buckets. Okay, so a list of all these interventions that each intervention should do what? Address a gap in the process, right? No free-floating interventions, right? So each intervention should be directly linked to a gap. And you start prioritizing these, right? You can actually red, green, yellow these over here, right? The green are the ones we've accomplished, the yellow we're in process, the red we haven't gotten to yet. Remember what I said? These changes have to be very deliberate over time, right? If you say, okay, here's our 8 changes or so, do you want to do all this at once and just throw it at the control chart? No, you don't know what's worked. Okay, so that's the science part of it. It's almost hypothesis testing. Well, it is hypothesis testing. Here's my hypothesis on this change. Here's how we think it'll work. And for each of those interventions, you can use something like this, which is a PDSA form that plans the change. How long will it last? Who will do it? What's the measure? And there's 3 things that can happen with each change. And this is when you get down to the study and act part of PDSA, the plan, do, study, act. So you study it and you say, did it work or not, based on your measurement. And this would be very small amount of data that you have based on the change. You say, did it work? Well, there's 3 things you can do to that change. It's called the 3 A's. The first A is adopt. You adopt the change. And then you can say, hey, this might work full scale. Okay, let's do this. This is the new operating procedure. We have to change our policy. This is the way we're doing it, right? It reduces the emissions. So we can adopt it. The second A is we can adapt it. We keep the change, but we tweak it a little bit because it's not working just right. So you adapt the change and retest. Or the third A is abandon. And rarely does this happen. It's like, okay, nothing worked with this. It doesn't even make sense. We're just going to throw it away and get ourselves a new change. So if you plan the PDSA appropriately, abandon is usually not in the cards, unless you just kind of have a bad day. But you either adopt it or tweak it a little bit to make sure it works a little bit better. And if that is working better, then you go to the next change. Remember I mentioned the project management piece of this. The project management pieces, I like to use a RASCI tool. I do sort of RASCI tools. Oh, these are cool. Okay. This is how you hold people accountable to each change. Okay. And this is really like you have an executive sponsor or a lead on the project. Really, this is the project management piece that they will guide. So you have each action of how you're supporting these changes and who's responsible and accountable for it. Put names on paper, and that's who you hold accountable. Sometimes that's not easy. That's all part of the fun of the process. And then you can put due dates in there, you can put updates. So every time you start a meeting, every time you give an update at a forum, go to your RASCI tool, go write down things that are working and things that are behind schedule, who's accountable. If something's behind schedule and that name's on there for the accountability and responsible factor, guess who you get to call? What you call. Okay. Don't blindside people with that, but you got to put names to actions. So out of all that, we see if that change made an effect. How do you do that? Look at changes in the data. After PDSA 1, let's say we had a big intervention on increasing follow-up phone calls, and our process data says, yes, we have increased that compliance. Does it have an effect on the outcome? Well, we look at our data over time. So yeah, it did. Okay. Look at that. We met goal, perhaps. I think we're ready for PDSA number 2. Let's drop it even further. Okay. So you go back to your key driver diagram and grab that next intervention. Okay. Some of these PDSAs can take a while to monitor. The effects of them can take a while, but it's all based on how often you measure the data, how quickly you get data, and what the effects are. But be very deliberate in the cycles of change. So next steps, I want you to think about projects that this could possibly apply to. You see things out there, I know we all do. Start identifying things that could go through these methodologies and relate to good change. Think about the problem statement, because you have to have it's almost like a business case. Why is this important to the organization? Right? Strategically, this is very important. Then I urge you to ask the 3 questions in the IHI model for improvement. Okay? That'll guide you to what possibly the goal would be, what measures you might need for process and outcomes. And it gets you in the early stages of thinking, well, what are some ideas for change? Okay, that's the 3 questions. And then, this may be a little difficult at this moment, but start thinking who you might need to get involved. Start thinking about that project charter. How do you fill out that project charter? So who should be involved, including an executive sponsor? So just give that some thought. Start going over this in your head. Nothing has to be, baked fully. And always think about how you observe the process. How would I know where the gaps are? What's causing the problem? Right? Things like asking the 5 whys. Right? There's a gap in this part of the process. Why? So that's why. That's why a lot. So you're always asking why. All right, and the analyze phase is it's basically root cause analysis, finding the causes for why those gaps are present. Start thinking about that as you're working every day, as you're providing care every day. Start thinking about the processes you're going through. Are they efficient? Are they effective? Right. That's the mindset. That's the philosophy of all this. That's the safety and quality mindset I just described there. Always have that mindset of how to improve this. So once you go through those next steps and kind of formulate this, I think we'll get back together, right? Get around some tables, whip these tools out, and start putting these things together. Right? It's pretty cool. So let's make some smart aims. Let's talk about your projects. Let's put some key drivers to it. Okay? I might show up with packets that have all these templates in it. You never know. Bet you I do. So, let's schedule that. Give it some thought. Give these ideas some thought. Right? It could be clinical, it could be non-clinical. Talk to the folks. See what's possible. Okay? Tons out there to improve. I will, there's a good reference here. This is the Institute for Healthcare Improvement website. They have something, you may be aware of this already, there's something called the Open School. Yep. They have quality modules, safety modules, they have modules on everything we just talked about. So in your free time, um, maybe utilizing open source, a great resource. And on the IHI website, you can go in and there's the essentials toolkit. There's some templates that will look very familiar to what was on the screen today. So dig into IHI a little bit. They have a lot of good resources and they have a lot of videos, not only in the open school, but you can find a lot of this on YouTube. You can type in IHI key driver diagram, Don Goldman or somebody, whoever does the video. You can find them there as well. And they're short and pretty instructive. All right. All right, any questions? Strike that, those are questions. Any questions or clarifications? Yeah.
Thanks a lot for talking. Appreciate it. I just kind of want to encourage, just kind of add on what you had said at the end of our thinking about projects on you. Feel free to pair up, and it doesn't have to be in a silo. Some of these projects, it's a lot to them, and you get a lot more done in groups. As far as recommendation requirements for you being in a UI project, participating in those, doesn't mean you have to do them by yourself. It's very helpful to get in groups of folks. You know, we've got 10 of us in this intern class. We want to get in groups of 2 or 3 to kind of get together to say we can together do more than by myself. Feel free to do that.
Excellent.
That's what all have to be just in pairs too, so like, if, you know, if there's somebody in the class above you that is thinking about something and getting it started, that's also an option.
And if you are interested in thinking, hey, I might want to do cardiology or GI, let me know. The cardiology GI departments and Dr. Sethi knows what to say. If there's ways in which we can collaborate with those fellows, particularly, they use the projects as well. It can be mutually beneficial in those situations. So let me know about that and help coordinate that.
I personally want to thank Dr. High, Dr. Carr, Dr. The state's leadership and good buy-in from the highest levels of the organization. It's so important how we train and how we improve the system. Any other questions? There's my email right there. Everybody else has emails too, so we're here for you. We're here for you. And record service on this.
Thank you so much. Thank you.
All right, thanks, guys. Appreciate it.